Good afternoon.
Good afternoon.
Hi, hello. So this time is to discuss anything you have on your mind, your feedback, reactions to the themes. I do have a couple of prompting questions, but we really can go anywhere we need to go to be sure that we get your feedback. So first off, to just start off with, what were your impressions when you read through the report that came out last week? Were you struck by the themes? Were they comprehensive enough? Did they address things that you thought we needed to have about the crisis system? So just what were your impressions as you read through the themes? And I support you to talk to each other as opposed to talk to me. I'm here just to help you to get to talk to each other and take notes and make sure we do some reporting out.
Well, I just wanted to say, first of all, I was a little confused as to how an integrated system could create bifurcation of the crisis delivery in our state. I mean, one is about bringing together and pulling in, and the other is about splitting into different branches. So that I didn't understand that very well. I was appalled to see a big zero next to, I believe it was crisis stabilization beds in more than one county in our state. That's sad. As a certified peer counselor, I totally endorse the idea that peers are underutilized. We have a pretty good sized and very well trained peer workforce in Washington state. And I know that because I was one of the people that helped start that back in the early 2004, 2005. And I think that I see that theme or that sub theme repeated, and not just in this context, but in other places and other meetings. But I don't see a plan to ever change it. So that's where I'm going to be most interested going forward. Is if we can acknowledge that it is underutilized, how do we propose to change that?
Mm-hmm. And Kathy, some of the work is like just getting this lay of the land to figure out these subcommittees. Where do we prioritize? And what is the work? And I'm hearing, that's probably one of the areas to focus on is bringing it up more alive. That there are peer workers, and how do you bring it more alive? Others' reactions.
This is Kashi. I work at Seattle Children's, and I am going to sound like a broken record, and I'm going to submit written comment about it too. But I think if we don't scope or state the population that we're talking about, we make assumptions that it covers the full spectrum of age, and I don't think that's true. And I will also caveat by saying that when you ask for feedback, you get constructive feedback, and this represents a huge body of work, and I appreciate that. And when I look at, theme 1, for example, the availability of the continuum of services, I'm concerned that does not reflect the available continuum of services for people under 18. And so if you think about mobile crisis teams, there are not youth-specific mobile crisis teams in every region of this state yet. I don't believe that youth are eligible for those crisis stabilization beds at all, which means if you had a graph of youth available crisis beds by county, you would see 0 across every county. And someone can correct me if I'm wrong, but I've never seen crisis stabilization beds used for youth in that way. And so I think we should call out what youth have access to in this continuum specifically, or we will assume that they're working within the same system as adults. And I don't think that's true.
So prior to COVID, Carrie, just so you know, the CRIS had what they called hospital diversion beds, and they were somewhat a crisis stabilization bed. It was a therapeutic foster home. I don't know, with COVID, everything changed.
Yeah, hospital diversion beds, you're right. Thank you.
Kathy, can you just say that again? Because I hadn't heard that before, and I want to make sure I capture for future that there's therapeutic foster homes that can be used for crisis stay.
No. So if if a youth with mental health issues or behavioral health issues is in crisis in their home, but we don't want to hospitalize them, but we don't want to leave them there and let things escalate, they could go to what's called a hospital diversion bed until anywhere from 24 hours to a few days. And the beds, if you will, were located usually in therapeutic foster homes where the parents had been trained and licensed as therapeutic foster parents.
Okay. And just to clarify, are you saying that that's something could be, or it does happen?
It was in King County since May of 2005.
Okay.
But I do not know what is going on during COVID because that is a completely different animal.
Mm-hmm.
Kathy,
And
do
I
you know
don't-
whether were they Medicaid kids or was it any kid? What do you think?
I had clients that were private insurance and I had clients that
Okay.
were Medicaid.
Okay.
Do you remember any
accessed them.
outside of King County, Kathy?
Pierce County.
Pierce?
Yeah, I think we'd have
That's
to do
about
some
it.
looking and working with DCYF, Kathy, but I remember for sure King and Pierce.
Yeah.
Yep.
I think
Yep.
Snohomish County too, but I don't remember it again. Everything changed with the COVID.
Well, and also Kathy, I think to some of the point in the feedback that we have is that we call different things in different regions. We call different things different things depending on which facility it's at. And so that's some of this too, I think, is how can we almost have a dictionary up at the front of the report? Because what we call something is not what it's necessarily called in the real world. And so, and I think also maybe some clarification about, while DOH may not license something that's, fits into what's called a crisis bed, maybe there is something with our Medicaid rules where it has to meet XYZ, right? And so I think some of that clarification piece and making sure that we're all talking about the same thing, that was, I think, some of my feedback on this is yes. However, I'm not sure that we were all singing off the same sheet of music on the key themes. Even when we read, I think we might have 9 different opinions of what those 9 things mean. And there's only 6 of us on this call. No, do you know what I mean though? It's like, I think again, and I love the lift. It's just, I want to make sure that we are all talking about the same thing when we look at, like Takashi's point, when we say continuum of services, what does that really include?
Who does that? Yeah. Well, who's included?
Yeah.
From the perspective of the BHOs who provided these information, well, one of the providers of the crisis information, because the MCOs also participated. There is, to Carrie's point, there's a lot of nuances that we included that couldn't be easily quantified or explained in bullet points. And in those, I think it captures unique aspects, even in response from a regional perspective for youth and for adults. And I think the huge thing we identified within that was there are certain beds available within a region, right? Stabilization beds, but it doesn't look at the overall challenges associated with operating a bed within that region. Ferry County has what, less than 8,000 people. So when you say there isn't a stabilization bed, is it feasible to expect one could be operated within Ferry County? How about Pend Oreille County or Adams? And I think that's where the challenge is. We forget about the unique frontier rural community needs. And so it isn't as quick as saying, well, there's no stabilization beds here, so they're underserved, but is there accessibility to them? And I think that's where the healthcare authorities really work to look at connecting those. Ensuring that there's accessibility may not also mean that there's one in that region. And even in Spokane, we operate the Alliance ENT up in our Stevens County, and they want to get rid of it because of the headache of operating one is just enormous. And so even with availability of beds, the challenges associated running with them administratively is so burdensome. So I think looking at this, we have to look at the nuanced approach. This is my first perspective, is what is available, and not just what can we add on, but are we sufficiently identifying what is already there, ensuring that that is sufficiently funded and available before we begin looking to expand? And do we comprehend, again, back to Carrie's point, the correct terminology we're utilizing? for what sort of response, because when I hear stabilization beds, I think as a clinician, a level of care for medical necessity. I do not think of what's paying for a license, which is unique, but other individuals have a different perspective, and the same with ENT and hospital. So I think if we can get back to that, even I get in a bad habit as a clinician. I look at this from a different perspective, and sometimes I have to come back and think, oh, there's other ways of looking at it. As Kathy indicated, there's other resources that may not be medically necessary based on their contract, but are available. So I think that was just my quick perspective from BHASO was, oh, that's really weird looking at it from this perspective.
I think one of the things I just want to like, those themes are not like, this is not what we should do. This is just by virtue of looking at reports and having conversations in the community forums. These are the things that came about, and we can only report on what came about or what the information is. So just like, so Kasha, your point about the kids, we didn't have that, we didn't find information that does that delineating, you know, and so maybe the fact that we don't have that is then one of those next steps of, we need to be sure that there's reporting in a way that allows to see the accounting of what, you know, are there kids beds or not kids beds or mobile teams or, so I just like what we put on those reports is what uncovered, and what we didn't report is like, well, maybe there's a need about that.
Yeah, I mean, it would be interesting to know, given the fact that the BHASOs are insurance blind when it comes to crisis services. Just number one, just having an understanding of the beds that are out there, how often are they full? Would be really good information, because if the idea is you want to figure out whether we need to invest in more beds, you need to know whether the beds that we have are being used. And then, I mean, the other thing that
Jane,
Terry,
just to tie, I don't want to, I just want, so what you just said, like that kind of connects with like theme 9, which is there's the amount of like the data that's collected and knowing like what we collect going forward, getting real clear about those so that you can know how many beds really are there, and are they for kids or adults, and special needs. We hear a lot of that, you know, like special needs. How do you even know what you have? How do you know what the capacity is?
mm-hmm.
Yeah. Okay, Jane,
And then
you go to another
Carrie,
one.
question for you.
Yeah.
Could the MCOs give us ED utilization for behavioral health conditions?
I'm sure we can make that ask. Yeah.
Because I mean, that's
a good one.
Kashi, I'm assuming Children's has boatloads of data about ED utilization with kids with psychiatric diagnoses.
I think the Washington State Hospital Association is looking at some of that too. So we could ask them for that, because I mean, statewide and nationwide, we're seeing growing proportions of, I'm talking specifically about kids, of course, kids coming to the ED with mental health issues, and MCOs, are they going to be able to represent commercially insured kids in the state as well?
No, but I mean, we actually, our data is old. We asked On Point to pull data out of the all payer claims database for behavioral health service utilization. And we've got data, but it's the last year. Don't ask me to tell you how hard it is to put together a data set that includes approved, paid and denied claims for behavioral health plus med-surg. But we do have data for a period from like 2017 to 2018 that has information about ED utilization broken out by age groups. So we've got kids. And that's for just commercial health insurance.
Yeah, I wonder, I think
Carrie,
there's something there with that, Jane. And also I think we can engage with Department of Health on some of their, Suzanne, Department of Health has some stuff with their sit reps, with their situational reports on data around youth utilization of ED right now, broken out by, I think, Kashi, you've seen them as well, right? It's overdose, suicide attempt, and I think there's a couple other things.
I think ideation is in there too.
Oh,
Yeah.
perfect. Yeah, thank you. So yes, all of
I-
those, I think, to maybe getting a little bit more of a
whoops.
grounding around that, especially from the children and youth side. Yeah.
Yeah, Suzanne, I just sent you the link to that report that we did. I didn't
Yeah,
realize it.
I took a quick look at that. I've never, in the different states I work, I've never seen that kind of data on the commercial. So that was some pretty impressive to be able to pull that for the commercial kid, with the commercial.
Well, it's the
overall.
advantage of having an all-payer claims database.
Yeah,
But it just seems like if you want to get a full picture of crisis utilization, if you look at our data,
mhm.
what you can see is that it's disproportionately hospital EDs for mental health services for crisis. So that's a big piece of the picture. I think we know we want people, Carrie, I don't know what the most recent boarding numbers are, but we don't want people to end up in hospital EDs. And I can just tell you guys really quickly, we're working on, Carrie probably knows about this, we're working on request legislation next session to align the federal No Surprises Act with the state Balanced Billing Protection Act. And we put out a draft for feedback. And in that draft, we're proposing to amend the definition of emergency services in state law to include behavioral health crisis facilities, so that private health insurers would have to cover those services, whether they're in network or out of network and without prior auth. So we actually reviewed that with Representative Davis and the BHASOs on Friday of last week. We'll see what kind of input we get from the world about that provision and whether it stays in. So
That's great. That gives me goosebumps, Jane, honestly. I think I told you what our team said, eloquent. They thought it was eloquent, so.
yeah. Well, it seems like it's needed. I mean, if the
Absolutely.
premise is the hospital ED is the wrong place for somebody for a kid or an adult having a behavioral health crisis, then it seems like we shouldn't limit the definition of emergency services to hospitals.
Can I add one thing on the data point as well? I think if we're going to go looking for youth-specific mental health data, I would just strongly encourage us to look further back than 2019, because I'm seeing 2021 data compared to 2019 pre-pandemic, and I firmly believe we were in a mental health crisis for youth before we were in a pandemic. And I've watched our ED census over the last 5 to 9 years. And what you see is a sort of pattern of seasonality in terms of emergency department visits, which is consistent with adolescent behavior. But the curve itself rises year over year from 2014, and 2019 was about the highest that it got, right? And then 2020, it takes sort of a dip. And so if you look at 2021 and you compare it to 2019, you think the data is normalizing, and it's normalizing to the crisis state we were in prior to the pandemic. And so I would just strongly encourage a wider aperture when we look at data. And then the second thing I would say is when you connect the sort of data component to theme 9, I will just state, make the implicit explicit, that there's a difference between process metrics and outcome data, right? I want to know how often those beds are filled, and I also want to know if they do anything to help people get better, right? And those are two different data sets. Those are two different questions. And so I think both sets of those data will be really valuable, but I don't think the sort of occupancy data is the same as outcomes for kids and families or the adults using the services.
So Kashi, you want to know how many kids are coming back to the ED,
Yeah,
or how many people are going back into the DCR system.
right. Or how
Right.
many kids end up in crisis after they, yeah, we started tracking it for a bit, and I don't remember if we're still doing this. My apologies about how many kids actually had outpatient providers when they present to the emergency department, right? You're tiered somewhere, or you're seeing providers, but you're still ending up in crisis and here in our emergency department. So it was just, there was some interesting learnings from that, and I think that would be a theme as well.
Yeah.
We don't
did-
have tiers anymore, do we? Or,
No, that's my archaic language.
okay, I was gonna say I got confused.
We did
so-
hear, let me just to.
Go ahead.
That some of the data points shouldn't be just the process measures of outcomes from the crisis system, but from other, like police data, 911, EDs, like there needs to be multiple data points to be able to get a good, clear picture. Like to just see how many mobile teams goes, you don't know if kids are still going to the ED. So you need all of that information.
And I think in Washington State, those things that you just named, Suzanne, those are part of our crisis system.
Exactly.
That is
it's just
good, yeah.
it's just not like packaged. And you know what? Every state you go around the country, there's pockets of like states they do have it packaged, but most states are in the process of how do we package this? Like the EDs have it, and they have that, and they have that, and they have that. And how do you pull that data together to get a real good picture of what is and is not happening? And that's how you can do your system improvements going forward. But being able to have it real time when you need it to understand.
Carrie,
So that data we didn't find it collated anywhere. Like we're piecemealing. We got some from here,
yeah.
some from here, some from
Yeah.
here.
Yeah. I meant continuum,
Yeah. Yeah.
Carrie,
It does. Yeah.
Kathy,
Yeah.
I asked you to go on hold for a moment there while I just made that point about the data that we heard people saying we need to have a better picture collectively. You were going to say something, Kathy?
Oh, I was just gonna say, what Kashi was saying about, how do we know that people got better? How do we know that the intervention worked? And if we don't have a follow-up system, we don't know. If we have a mobile crisis team that goes out to a house and we went to this address, we saw this person, we said these words, we left. There is no data implicit in that other than mileage. So
so what happened?
I know that people feeling better is soft data, but it's still important for somebody to find out.
Justin, we at that level, when DCRs go out, there is local tracking of that information. Is that right at the BHASO level? That does some of that get to what Kathy's asking? I wonder that.
Yeah, so every time a crisis event occurs where a DCR or a mobile crisis team goes out, and again, definitions, right? In small rural counties, mobile crisis teams are the DCRs. They're all one-stop shopping. They're also the outpatient provider, and they're the on-call administrative staff. So let's be clear on that. They're pulling 4 duties at the same time. So when they go out and provide a response for Medicaid and non-Medicaid individuals, including commercial plan, a follow-up has occurred. And in our frontier rural communities, usually a crisis plan or follow-up is required because they don't have immediate resources for an inpatient or stabilization bed. In fact, they have no single bed certs in our frontier rural communities, except for Spokane County. So they didn't even have that available. So community hospital ED is the only placement other than home in our frontier rural communities. And so when we talk about EDs as well, that's a unique definition. And so when that's generated, that data then is collected. And for the managed care organizations, they get a crisis report on a daily basis with all that information, including the follow-up. So they're provided that. We have nowhere to send that data for the commercial plan individuals. So that's maintained internally. And so we ensure that that follow-up occurs. That also, I think we forget, is fee-for-service Medicaid individuals, which includes AIAN individuals, because they don't have care coordination teams other than the ASO, which is an unfunded part of the requirement for the ASOs to follow up. And so I think that's another aspect that is unique for tribal members who are involved in tribal IHCPs or tribal governments who are actively engaged. Those are also, we have a mechanism to transmit over. Unless they specifically request, most of them are overburdened. And so with the new inclusion of tribal DCRs adds another complexity. They don't have to report to the BHASOs. They're independent and internal. And so all they have to report is the involuntary orders. And so how does that follow-up occur too for tribal individuals as we onboard tribal DCRs? So yes, but then we begin to look how this begins again to get more complicated depending on where you're at and the location and the service being provided. The only one that kind of culminates all of that information together is really King County, because they maintain all of that in-house still for the managed care, including the Y services. So youth is included. And then Kashi, to what you said earlier about there is no youth mobile crisis teams. Well, all of our mobile crisis teams don't exclude, but there's none specifically designated for youth, right? That's forthcoming in the January 1 contract amendments for House Bill, I'm forgetting the House Bill, okay. But yeah, that's coming. But then we get to this question of how long, because we don't have a workforce. So it'll be existing members until that occurs. So stuff on the horizon, but yeah, a lot of tricky things in how we track.
So Justin, what does follow-up look like in your region?
So again, case by case scenario, but let's say it's an individual who is detained, right? So that's the highest level. If they're detained and it's in a frontier community, they're taken to an ED for medical clearance. They don't have access to King County beds, because the moment they're put into a community hospital ED, King County courts say that's boarded. We have no other placement, as it's not a single bed cert. We won't accept those. So our DCRs cannot place in the King County bed. The courts will reject those. And so we've had them be sent over and then sent back on a cab saying they're significantly mentally ill, but we won't detain them. And so for those, follow-up occurs with finding a bed placement. If one is not available, which does occur, we used to actually place them in Eastern State Hospital for adults. For children, again, there's very little resources out there like Kashi spoke to, but there is out of Spokane. And then that DCR would then coordinate services discharge placement back to the community once discharged from the inpatient facility. For those that are community placements, usually you would have a tiered system, right? You would have under, and when I say by tiered, I'm saying level of care, which would be EMT, stabilization, partial hospitalization or day treatment, right? And then intensive outpatient. None of those are available in frontier communities except for intensive outpatient on a case-by-case basis. And so for those, the DCR is primarily the community liaison to engage that person back into their home with a safety plan. And that's really challenging because they're the only DCR on for the whole county. For voluntary placements, we thankfully, the legislature passed that law that allows transports for AMR, because that's the other thing. We couldn't get people transported under voluntary. So you saw an increase in ITAs, partially because if they were left alone, there wasn't transport, ITAs were the only way to get paid for. And so that played into the factor as to detention and availability of resources. Now that we allowed for voluntary pay under the healthcare system, remember, not all AMR services or ambulance services go to all rural hospitals. So for the ones that do, we can actually transport them to a stabilization unit. But those are generally outside of our region if the ones here currently are full, which includes Wenatchee, Yakima Valley, and in Seattle. So the other aspect is,
Jane asked, like, what do you do for follow-up? And
so
what your response is exactly what we experienced as a whole of, like, there's just so many nuances and complexities and differences and not standard reporting and not having standard practice expectations that we expect. Every phone call has a follow-up phone call of a mobile team. Like, there's just these variations, and I think what you expressed is like great work. People are doing a lot of things, but it's just kind of it's not understood. There's not information, and people asking, particularly in the forums, like, how do we simplify, particularly for those who participate, receive services? How do you simplify to know, how do I just ask for help? Don't tell me about the courts and the this and the that. Just help me, understand that, if I call from my kid, someone's going to help me relax, and maybe it could be another parent, and that's all I need. And then we, including myself, professionals, we go into all this. Well, we have this criteria and that criteria, and we just heard, like, there's lots of opportunity to simplify and standardize. So when Jane asked a question, well, what is follow-up? We'd all be able to say around the state, within 24 hours, whatever it is, there's some follow-up, and we know people are taken care of.
Yeah, and I think to a certain point, though I'm not the specialist on these, the contracts, to a certain point, there are contractual obligations that are met from a timeliness standard. And then the ... after that is, and so then what, right? And so I think there's so much nuance to that too, when we know workforce is an issue, we know funding is an issue. I'm going to agree with all of the key themes. And and say, like, yes to setting standards statewide, but then also there's so much of that other stuff behind the scenes that the MCOs and the BHASOs and providers on the ground are feeling. And how do you make sure that there's a standard without saying, like,
Enough of
you're
a
going to meet
standard
it no
without
matter what?
prescriptive.
Yeah.
Yeah, that's not easy to do.
It's not.
And we heard a lot of people asking for that. And I just want to remind us is that we just reported out what we heard, what we had access to. This doesn't talk about solutions or what needs to happen. It's basically an inventory.
I am happy, honestly, that the funding of crisis services was something that came up. The difference in funding, I think it's just important for folks to know, and I'm not making a value statement about it at all. I'm just saying, I think it's important for people to know how the crisis system, regardless of insurance, regardless of Medicaid, regardless of block grants, of how it's funded, because it's complicated as heck.
Yeah.
My goodness, they're telling us we have 10 minutes left.
And Suzette, I have one thing that I wanted to bring up that I noticed wasn't clearly identified, and that is the uniqueness in how that crisis service is provided for the non-Medicaid population and for those AIN individuals as well, because there's an aspect that wasn't covered, the within available resources and not. While you may see more information regarding those that go to an involuntary service versus not all regions have availability of funds to pay for voluntary services. Thus, their data will demonstrate a unique shift towards involuntary treatment services because that's all that's available.
So the
Spokane
lack
County,
of funding for voluntary
Yeah.
precipitates that push to the thing. You have to wait till things get real bad, and then voluntary gets kicked in.
yeah, or that's the only data that they will demonstrate because they don't pay for the other aspects. Now that's a very nuanced approach to that, right? Because there's a bunch of other services that may be voluntarily based that they pay for that isn't specified under the crisis contract. But if you look at the crisis contract specifically, I think it's important to notate the voluntary and available within available resources, which is not similar across each region.
So I just want to say, when we go back to the main room, I think here, these are the few things I'm going to report out on. And if there's something else you think I need to, but I heard first off for theme 1, there needs to be a way to identify this continuum for both kids and adults. That needs to be, they need to have an awareness of in the utilization of services, or that really goes into two, but you need to know between kids and adults. I heard things like there is data, but it's in different places. And I heard that there's different kinds of data that people would like to see beyond just some of the reports that were here, but there's other ways of measuring ED use. And then there's also this concept of the Medicaid and non-Medicaid, or the commercially insured. There's a need to know the differences of those. What else should I focus on to make sure we bring back to the group?
So I'd like to go back to Carrie's original comment, which is that we need a glossary at the beginning of this.
Okay.
How are we defining crisis services? How are we defining stabilization bed or stabilization services, which could easily be both in network, inpatient and outpatient.
And what about ENT and all these other acronyms too, because that falls into that same grouping, yeah.
But I mean, Carrie's guys know that. Carrie, you have the infamous David Johnson list
absolutely.
of all of the licensed stabilization facilities. It's what we have at the end of our report. We have a list of them.
Yeah.
That's based on your the list that you gave us, and I think DOH gave us. So we basically blended your info and DOH's info to come up with that list.
To kind of create our own little version of the green book. perspective.
Mhm.
You
So
know,
it's interesting, the Green Book, Carrie, we went through that, but you can't tell who's doing crisis services. So it's a very helpful resource to know to make calls. But for like, that didn't help us dissect. We had to just focus on some of the.
well, so the Green Book, the actual Green Book, the mythological Green Book that's very, very helpful doesn't exist in the form that it exists in now. So what we maybe directed you to, the DOH website.
We went to the DHO, right, the website.
Yeah, that's a version of the Green Book that, Jane, back in the day, the Green Book that was, that paper Green Book really did include all of the, if you were a crisis service and that sort of stuff, didn't it?
I can't remember.
Yeah.
I cannot remember.
Yeah.
Wasn't the Green Book primarily for SUD resources,
It was, but
not
there
for
was
mental health? I'm trying to remember.
Well, you're
It
right,
was-
Jessica, but there was also quite a bit of that crisis piece layered onto it.
Yeah.
But yeah, Jessica, you're right. So
Would it be fair that I share that we talked about the themes, but we also found ourselves like kind of getting into like the things that need to have that come out of those themes, things that we need to solve for the future? Or is that not an accurate? Because I felt like some of your conversations, well, here's what then we need to do. We didn't go into detail of it, but would that be fair to say that, or is that not true for?
I don't know. I mean, just from my perspective, in terms of the work of the CRIS committee, at this point, I'd focus more on defining the baseline and making sure, because if we're going to develop policy recommendations based upon what is, we want to have a good description of what is.
and I would agree with Jane. I think that the themes led us to get to that solution-oriented focus, but I think part of the why behind that is, again, maybe we all view the themes as the same, but those meanings behind what's behind those words, of all 9 of them, are different for each of us. And so I think that's where the conversation for me kept driving us to, is still trying to find that point of agreement, or us trying to really find out the there right now.
I agree, and Carrie, correct me if I speak wrong on this, but I think that for me, this is less about solution jumping and more about working from a shared definition, both of the crisis system and of the things we want to understand better. And so I think there are lots of things we said we needed in this conversation, but we haven't started to talk about the solutions for this system. We do need to better understand what's happening in this crisis system. And that starts with a shared definition of how this CRIS committee is defining crisis system, because emergency departments are a part of the crisis system in this state because they have to be.
And
I would
think
agree with that.
One of the themes is that everyone we talked to, they had different definitions of all that, what was in, what was out. You would hear people say, well, the crisis is just the mobile team and the call center, the others is out. And so I think the community coming to agreement of what is the crisis system and having that in a definition that everybody agrees on.
Yeah,
There's,
I mean,
in contracts, there's some good language, but when you talk in people's shared understanding, it's different.
but I mean, given EMTALA, the hospitals have no choice. They're part of the crisis system. They're obligated by federal law because a behavioral health crisis is an emergency under the prudent layperson standard. So, and like I said, they're not the right place, but they are absolutely part of the system.
Yeah, and I would agree with you. We heard other people not having, not a shared understanding of definitions.
Which is why it's
seems
so important to have a glossary. Go ahead, Jessica.
Oh, I was going to say, and I apologize for jumping in late to this. I had to step out and got bumped back in. But I think too, the different definitions also reflects different regional experiences of the crisis system. So, a lot of discussion about, well, in some places, the mobile crisis team is DCRs, and in other places, it's a separate team. And in some places, the law enforcement or co-response as part of the crisis system, and in other places it isn't. And it really reflects that our system looks very different in different counties based on what's available. Because I can tell you what the crisis system means to me in Thurston and Mason counties, but it's not particularly relevant in Pend Oreille. So really accessing the fact that that joint definition is what's going to carry this process forward, because we want to come to a place where we're incorporating everybody. And I agree with you that the ERs are.
Good day. See you in a bit. We're going to go back to the main room.